Hello everyone, welcome back to Karan Academy. My name is Karan and today we're going to be talking about glomerulonephritis or glomerulonephritis. Now this is again a huge concept and it's one that you would have touched base on in preclim. I personally think that GNs are made to sound much more complicated and harder than they actually are. Again, going back to my basic principles, I think if you understand what's going on at the actual cellular level, it's kind of one step back, but three steps forward, and everything makes much more sense. I promise you, if you apply these principles, I think you'll be super comfortable in understanding them and then developing a systemic approach to these conditions. Let's start off with a few basic principles. I'm sure you would have heard of nephrotic and nephritic syndromes. You need to know that these aren't actual pathologies. Like a nephrotic syndrome isn't one thing that's wrong with the kidney. These are clinical manifestations or clinical presentations, which most commonly tend to be a glomerular cause. What I mean by this is a nephrotic, when we say a person has nephrotic syndrome, we just say that he is demonstrating a pattern of symptoms that are consistent with a glomerular pathology, and compared to nephritic syndrome, there's going to be obviously different symptoms. The exact combination of symptoms that the person's presenting with can often help us narrow it down to what might be causing the certain presentation. Understanding all of this is not compulsory, and I'll be really honest with you, you can get away with getting most answers by just knowing associations and having a system that way. I just personally think that if you can understand it, it just makes things so much easier, because that's just how my brain functions. Okay, so let's draw a bit of a spectrum, right? And this is really important. So you know that a few important presentations might be firstly proteinuria, where your kidneys are leaking excessive levels of protein. And this is very typical of nephrotic syndrome, where you have more than 3 grams of protein being leaked a day. On the flip side of that, you might have hematuria, which is blood in the urine. And that's very typical of nephritic syndrome, right? What I want you to understand is that yes, some conditions can present with a predisposition to one over the other. For example, we know that minimal change nephropathy almost always presents with proteinuria versus anti-GBM and certain vasculitides that are almost always hematuria. However, the distinction kind of fades away and we go into a bit of a gray zone in between. What I want you to get by this slide is that although we like to classify conditions as either nephrotic or nephritic, there is considerable overlap. You can have hematuria with a high degree of proteinuria. You can have proteinuria with hematuria, and you can have both of them in very high levels, right? So this, I think, is so important in understanding everything. I feel like if you understand this page, you will understand almost all of GN. So this is your glomerular filtration membrane, and it has 3 components to it. Firstly, you have the fenestrated epithelium, which is the innermost part, and blood will be passing through this. You then have the glomerular basement membrane, and then you have the fenestrated epithelium. You have the porocytes, or the slit membrane between the porocytes. You also need to know what each one of them does. The fenestrated epithelium holds most blood cells and immunoglobulins, or let me rephrase it. It holds most blood cells in. The glomerular basement membrane and the fenestrated are both mostly large proteins and RBCs, while the slit membrane between the porocytes, because they are charged, negatively charged, they prevent the passage of medium-sized proteins through them. This is really important because now we have 2 membranes, and depending on which one we damage, we will have a different presentation. So hypothetically, let's say, if we have a condition that's damaging the fenestrated epithelium, which typically holds back RBCs, if you don't hold back RBCs any longer, that's going to leak into the urine and present with hematuria, right? Versus if you have a condition that's affecting the porocyte membranes, you will now start leaking protein, and that is going to present with proteinuria. And if you have damage to both of those, you can have a condition where you have leakage of both of them. And we will keep coming back to this very principle when we talk about the different GNs. So let's start off with nephrotic syndrome. In nephrotic syndrome, we have damage to the podocyte slit membranes. Now, I'll very briefly touch on how this damage usually happens, but I don't think it's super relevant to know. When we talk about nephrotic syndromes and damage to the podocyte membranes, one thing that you'll see is that the membrane is on the outermost part of the actual filtration membrane, right? And therefore, the damage to the podocytes is often something external or extraluminal, which means that the source is not coming from inside the vessel, but from outside the vessel. And that kind of makes sense because it's on the outside, right? Now, what this actual damage is very, very complex. And you have different kinds of nephrotic syndromes. But the broad principle of this is that you have usually some form of inflammatory mediator that your body is producing. That tends to start off by eating up the interstitium around the actual lumen, so around this space. And in the process, because the fenestrated podocytes are the closest to the interstitium, that's the part that's going to be just incidentally damaged. It's just a passerby who's been instantly damaged. And once you damage this, you start leaking protein, right? That's the basic one-line principle of what's happening. Because the podocyte slit membranes hold back major proteins, one of the key features you will see would be heavy proteinuria, characterized by more than 3.5 grams of protein a day. Because you've lost a lot of protein, and one of the major proteins in your body is going to be albumin, you would have hypoalbuminemia in the blood. Additionally, because you now have low levels of protein in the actual vessels and in the blood, you know that one of the roles of protein is to pull water in, right? And now if you have low levels of protein in the blood, you will no longer be able to keep the water and the fluid content intravascularly. And this will lead to extravascular fluid expansion or edema. Now, the major organ that makes most proteins is going to be your liver, and your liver is going to detect this hypoalbuminemia. Oh no, I don't have enough protein. So I will now try to make up that protein by going into overdrive. Incidentally, one of the other things that the liver does is also make lipids and package lipids. So in a valiant effort to make up for that protein, you're also going to end up with producing a lot of lipids, and that's going to cause hypertriglyceridemia, which, as you can imagine, would contribute to the patient's cardiovascular risk. Additionally, a few other important proteins, apart from albumin, that we are losing include our anticoagulation proteins, so anti-C and anti-S. And if you lose anticoagulation proteins, that would increase your clotting risk. And lastly, immunoglobulins. So if you lose immunoglobulins, which are also medium-sized proteins, that might lead to a poor immune system or immunosuppression. So that is kind of the clinical spectrum you will expect with a patient presenting with nephrotic syndrome. The 4 important causes you need to know: minimal change disease, FSGS or focal segmental glomerulosclerosis, membranous nephropathy, and diabetic nephropathy. And I realize I've misspelled diabetic. So good job. Okay, so talking about minimal change disease. Now, as the name suggests, minimal change disease is seen as minimal change on light microscopy, which is why it's called that. In terms of what causes minimal change, we don't really know what is causing it. Going back to our basic principle of why we have damage to the podocytes, but we don't really know. We expect there to be some inflammatory mediators that have leaked into the interstitial space, are eating up stuff in the interstitium, and just because of that inflammation have damaged the podocytes. It is also associated with Hodgkin's lymphoma. I don't really know the exact mechanism of that, but a good association to know. What I would highly recommend you know is that it's the most common GN seen in children, and it has a relatively good prognosis. In terms of its presentation, it presents with a typical nephrotic presentation. In terms of edema, one important point I'd like to make is that the edema seen with nephrotic syndrome is non-gravitational. What does this mean? Now, when we talk about peripheral edema and edema in general, there are two reasons you can have edema, very broadly speaking. Well, there are many, but the 2 main ones are either because your heart is not able to pump well, which is why you have fluid accumulating in your lower limbs, your arms, which is why you have the peripheral edema, right? Because the fluid is not because you're not able to pump the fluid. And that's going to accumulate, obviously, in your lower limbs, because that's where gravity is going to pull the fluid down. The other type is because of hypoalbuminemia. Now, as I mentioned earlier, with low levels of protein in your blood, you aren't going to be able to keep fluid in the vessels themselves. And that's going to lead to fluid leaking out of the vessels into the interstitial space, causing edema. Now, unlike the edema seen in heart failure, you can imagine this would be happening everywhere, right? It doesn't matter where gravity is, because you are going to have low levels of protein everywhere, because your blood has low levels of protein. So you're going to have fluid leaking out of the vessels in your face, in your arms, around your eyes, everywhere, including the lower limbs. Versus you don't really see facial edema because of something like congestive cardiac failure, because you would not really have a reason for gravitational fluid to accumulate in the face. It's mostly going to be the legs. In terms of things we'd see on a pathology, you wouldn't see anything on light microscopy, which is why it's called minimal change disease. On electron microscopy, you would see effacement of the podocyte foot processes. What I mean by effacement is that instead of being kind of nice and well-organized slits, they will now kind of get destroyed, joined with each other, have bigger slits somewhere. So it's going to be really chaotic. And in terms of immunofluorescence staining, you're not going to have any staining show up because there is no immunodeposition going on. It's just inflammation. Some additional things to know: that it has a really good prognosis and remits usually well with corticosteroids. So these are the podocyte foot processes. As you can see, this is kind of a foot, which is why it's called a podocyte. And these are the slits in between them. Now, what happens with minimal change disease is because there's inflammation going on in the interstitium, you are going to lose some of those slits. You're going to end up with bigger slits somewhere else. And you lose this nice foot-like architecture all across the filtration membrane. And this is kind of what it looks like. So here you have nice foot processes with slits in between. And here, as you can see, you've lost that completely. Moving on to FSGS, or focal segmental glomerulosclerosis. In terms of what causes it, it's usually idiopathic, associated with HIV, heroin use, and is most commonly seen in Hispanics and African Americans. In terms of its presentation, again, it's going to present the exact same way, although it tends to happen in older groups. When we go to our light microscopy, what we see are focal and segmental changes. What I mean by, which is why it's called that. When I say focal, I mean only some of the glomeruli are affected. Usually when you take a biopsy of the kidney, you see a wide range of both the glomeruli, the tubules, the interstitium. You see quite a bit. With FSGS, not all the glomeruli are affected. Only some of them are affected, which is why it's called focal, and segmental because only certain segments or certain parts of the glomeruli are affected, which is why it's called focal segmental glomerulosclerosis, because you're sclerosing the glomeruli. Again, because there's no immune component to it, you're not going to have immunofluorescence staining. This, on the other hand, doesn't usually have as good of a response as minimal change does, and often progresses on to CKD in about 50% of cases. One point I'd like to make at this stage is when you apply this to your clinical reasoning, you would realize that in most cases, you wouldn't go around doing a biopsy for every patient presenting with a nephrotic syndrome, right? Obviously, you're not going to go ahead and biopsy a kid for their first presentation. So how do you approach that? Typically, what we see is you have a nephrotic presentation. If it's in a kid, let's say, the first thing we think of is a minimal change, and we trial it with a course of corticosteroids. And if it remits and resolves, we usually say, oh, well, that was minimal change, and that's kind of resolved now. However, if they come back with a similar presentation and it's not resolving despite corticosteroids, at that point, we might consider doing a biopsy. And in some cases, we might find FSGS. In some cases, we might still find minimal change. What I want to get across by that is we don't always know the exact etiology while treating the condition, because most of them are treated very similarly. Of course, if you have certain indications for doing an earlier biopsy, that's a completely different scenario. But very commonly, FSGS is considered to be on a spectrum to minimal change, where you can have minimal change and that may progress onto FSGS, but again, not very, very relevant when it comes to your exams. And as you can see, here is FSGS. So this part of the kidney is fine, this part's fine, this part's sclerosed. So you have a segment of one glomeruli that's sclerosed. Now, if I were to look at a wider picture, we would see some, again, affected very much like this, but then other glomeruli that are completely normal. Now moving on to membranous nephropathy. Now, what is membranous nephropathy? Now, unlike the earlier two, you actually have an immune component with membranous nephropathy. So how does this happen? Again, I hate saying this time and time again, but this is just what it is. The most common etiology is just idiopathic membranous, but a good association that you should know is that with solid tumors, especially GI tumors, can often so if you have a membranous nephropathy, always consider, could they have a tumor elsewhere? It also has a strong association with hepatitis B and C. And it's the most common cause of nephrotic syndrome in adults, while the most common cause of nephrotic syndrome in children is going to be minimal change. Presentation, again, it's going to be your typical nephrotic presentation. When it comes to light microscopy, we actually see thick glomerular walls. Now, the reason we see thick glomerular walls is because we have the deposition of certain immunoglobulins under the epithelium, which is why we have something called subepithelial deposits, and these form a spike and dome appearance. And I have a picture of that on the next slide. Because again, you have the deposition of immunoglobulins, you will see a positive immunofluorescence staining, which presents with a granular pattern. What I mean by granular is that it appears to be kind of dot-like, like granules, basically, versus the ribbon strip-like pattern we'll see with some other conditions. It usually has a poor response, again, progresses onto CKD, and for membranous nephropathy, we have the rule of threes. So 1/3 of them remit and doesn't happen again, 1/3 stay the exact same, and then 1/3 progress onto CKD. Now, very similarly, what's going on here? So you have the endothelial layer, you have the basement membrane, and then you have the epithelium. As you know, blood is going to be on this side, and if you have damage to the, if you have damage predominantly to the podocytes, which is why it's going to present that way, you will notice that the part that's mostly affected are going to be the podocytes or the epithelial layer, and you're going to have depositions of antibody and antigen immune complexes right under this layer, which is why it's called subepithelial. Now, that also leads to something called a spike and dome appearance, and that's purely because these immune complexes tend to kind of protrude out sometimes, causing that appearance. So this is the spike and dome appearance that's seen with membranous nephropathy. And here is a very pretty picture of membranous nephropathy granular immunofluorescence staining. And as you can see, it's not kind of consistent lines, it's kind of tiny, tiny dots everywhere. Although I will say you will never be, or very rarely be expected to just see an immunofluorescence staining and make that call, because it's obviously very hard to do. Diabetic nephropathy, now it's not exactly an immune-mediated process, but again, really important to know because diabetes is super prevalent in our community. High levels of blood, high levels of glucose in the blood lead to glycosylation of the vascular basement membrane. What this means is that you have an oxidative process where the high levels of sugar or glucose in your blood interact with that basement membrane and cause something called Kimmelstein-Wilson nodules. We'll talk about this and see what it looks like as well. The afferent arterioles are more affected than the efferent are more affected than the afferent, which causes glomerular hyperfiltration. Now, the afferent arterioles are the one giving the blood, the efferent are the one taking the blood away. How does that make sense? If you think of it, the longer you have kind of contact with that sugar, the more likely you're going to have that glycosylation process. And the afferent arterioles just being further away, means that they're often more predisposed to having that hyperglycosylation process occurring there. In terms of demographics, relatively straightforward. It's going to be diabetes patients or patients with diabetes. And in terms of presentations, it presents with mild proteinuria at first. So unlike your full-blown nephrotic syndrome, this will usually present with microalbuminuria to begin with, which can then progress on to higher levels of proteinuria. And by the time you have actual proteinuria or microalbuminuria, you can expect to see a very similar process happening in the retinas or diabetic retinopathy, because both of them are microvascular complications. In terms of pathology findings, you will see thickened glomerular walls with Kimmelstein-Wilson nodules, and the go-to medication for this is going to be ACE inhibitors, considering they are renoprotective in diabetes. And here you can see a Kimmelstein-Wilson nodule. Another point I'd make is when we test for proteinuria, there are two tests we can do. We can either do just, so the two spot tests we can do are the urine protein to creatinine ratio and the urine albumin to creatinine ratio. Now, you might be asking, well, why are we looking at a ratio? Why can't we just look at the exact protein content and make that assumption whether it's high or low? Well, if you think about it, this is just a spot collection, right? Both of these tests are done at one point in time. They're not a 24-hour collection. If you could do a 24-hour collection, that would be useful to tell you the total protein. But you can have people who are peeing significantly more than others. And if you were to excrete the same amount of protein and you test that on someone who's peeing way more, the amount of protein you'd probably catch in that sample is going to be much less compared to that of a person who's peeing way less and has a more concentrated urine, which is why we look at the ratio, because the creatinine and looking at that ratio kind of accounts for the difference in concentration. Now, you might be asking, well, do I do the urine protein to creatinine ratio or the albumin to creatinine ratio or the microalbumin to creatinine ratio? Both of them look at very similar things, however, and can be used mostly interchangeably. However, when we look for diabetic nephropathy, it's mostly done at routine checkpoints, right? Every 6 months, 12 months, whenever they see their nephrologist. We want to pick up the earliest possible change, right? And in these patients, you would often see microalbumin or albumin leaking first before you have gross proteinuria, which is why to detect diabetic nephropathy, you would use firstly a microalbumin to creatinine ratio or an albumin to creatinine ratio before you use a protein to creatinine ratio. I know that's not super relevant, but I just thought I'd mention that regardless. Now, what are membranoproliferative GNs? Now, these are a bit harsher and have a poor prognosis. You have now, much like membranous, you have immune complex depositions in the tram tracks, between the membranes, and that causes something called tram track appearance because you separate the two membranes a bit, and that causes that tram tracking like a train track. And it can have a mixed presentation. So you can have both proteinuria and hematuria, but it's mostly nephrotic or more so leaning towards the nephrotic one. In terms of pathology findings, you can have two types. You can either have subendothelial membranoproliferative GN, or you can have intramembranous. I'll just take you a few slides back and we can just look at this again. So where the protein or where the immune complex is deposited is very, very important. So if it is under the epithelium, as you can see here, that's subepithelial. If it's under the endothelium, or if the deposition was here, that will be subendothelial. If it's in the basement membrane, that would be intramembranous. And that is exactly what I'm going for here. So with type 1 membranoproliferative GN, it's subendothelial. And as you can imagine, because you've now understood why GNs present the way they do, with damage to the endothelium, you might have a higher propensity for hematuria compared to type 2 membranoproliferative GN, which is damaging more the membrane and is going to leak out more protein than RBCs. And there you go. Things make sense. In terms of prognosis, they have a relatively poor prognosis. And again, our mainstay treatment would be to give steroids. Now let's talk about nephritic syndromes. Now, nephritic syndromes present with hematuria, right? We know that the part of the glomerular filtration membrane that is going to be preventing that leakage of red blood cells is your fenestrated epithelium, as you can see here. So putting 2 and 2 together, in nephrotic syndromes, you have mostly a damage to this fenestrated epithelium. Perfect. That makes sense so far. Now, if I were to ask you, if you were to guess, where is this damage coming from? Is it coming from outside or extraluminally, or is it coming with the blood or intraluminally? And I hope you would be thinking to yourself, well, because this is on the innermost part that's in direct contact with the blood, I expect it to be more intraluminal damage and damage coming from things that are in the blood. And you would be absolutely right. Now let's talk about these. I've already talked about up to here. Because the damage is intraluminal, most nephritic syndromes tend to be because of immune complex interactions and depositions, because the immune complexes are going to be passing through the blood. I hope that makes sense so far, or would be immune mediated. The main ones are, firstly, post-Strep GN. It occurs with certain nephrogenic strains of strep, which affects strep throat, and this can cause a cross reaction at the antigen level. Presents usually in children 2 to 3 weeks after a streptococcal infection. In terms of pathology findings, you would see hypercellular inflamed glomeruli. Now, why are they hypercellular? Because you now have interactions, let me get that picture back. Because you now have interactions at the fenestrated epithelium, it's going to dilate and get inflamed and lead to the leakage of inflammatory molecules into the glomerulus. That's why you get a hypercellular glomeruli. In terms of an electron microscopy, you would see subepithelial humps on EM and a granular pattern of staining, again, because this is immune mediated. In terms of extra stuff, supportive therapy is usually the mainstay of treatment, adequate hydration and reassurance, and only 1% of children actually progress onto renal failure after post-Strep GN. Some adults, however, if they do get post-Strep GN, tend to have a worse prognosis. So if you were to get PSGN, I would say get it as a kid, not as an adult, because 25% of adults tend to develop rapidly progressive GN, which commonly leads to renal failure if they were to get PSGN. And this is what it looks like. So this is an immune complex deposition presenting as a subepithelial hump. IgA nephropathy, again, it is the deposition of IgA antibodies in the mesangium, or the tissue around the glomeruli. The first place that IgA is going to come from is the blood, right? And the first layer that it's going to destroy in the process or inflame is going to be your fenestrated epithelium, which is why it often presents with a nephritic presentation. It is the most common GN overall and is often synpharyngitic. What I mean by this is very commonly children who, and it does happen in children quite often, children and teenagers who present with a nephritic syndrome would have a sore throat at the same time. And you might be wondering, well, is this post-Strep GN? Because we know that strep throat and PSGN are a common association. However, they might be at a tendency for IgA nephropathy, and an infection in the throat might trigger that. Now, what's the main difference between the two is that IgA nephropathy tends to be synpharyngitic, which means it's happening at the same time as the sore throat, versus post-Strep GN, where the kid has a sore throat, recovers completely, and then 2 weeks or weeks down the track, they develop this hematuria. So that's a key clinical distinction to make. In terms of pathology findings, on light microscopy, you're again going to see hypercellular inflamed glomeruli with mesangial IgA immune complexes. Now, instead of it being in one of the 3 layers of the filtration membrane, the IgA immune complexes are going to be in the mesangial space, and it has a relatively good prognosis. Now talking about rapidly progressive GNs. Now, what are rapidly progressive GNs? And I'm sorry for the bad picture. It's taken from a textbook that's pretty old. A few ones that are important to know, or what I mean by RPGN is when you have something that's really destructive and really quick and affects almost everything, which is why most of these causes would present with a combination of nephrotic or nephritic presentations. So you can have both proteinuria and hematuria at the same time. A few important diseases to know are Goodpasture syndrome or anti-basement membrane disease, and that presents with linear immunofluorescence staining compared to most of the other ones which have been granular so far. And this is because of antibodies against collagen in the glomerular basement membrane. You can also have diffuse proliferative GN or post-Strep GN that presents with a rapid progressive GN picture. And the type of immunofluorescence staining in that case is going to be granular. Lastly, you can have RPGN that is not immune-based, and that presents with no immunofluorescent pattern, which is why it's called pauci-immune. The main ones include our different vasculitides, including Wegener's granulomatosis, macroscopic polyangiitis, or Churg-Strauss syndrome. Now, we don't really call it as Wegener's and Churg-Strauss. The reason we don't do that is because Wegener was a Nazi scientist, and we don't want to be calling our diseases after Nazi scientists. A good way to remember this, and I've tried to be good with my language so far, but the common test we do are the ANCA tests, which are a very common rheumatological marker used. And the two ones that come positive are C-ANCA with Wegener's and Churg-Strauss with that presents with a positive P-ANCA. And a good way to remember that is Wegener was a Nazi, so he was a C. C is short for something else, which I will not say. And the alternative being P-ANCA, that's Churg-Strauss. And here is a picture of what RPGN presents with. RPGN is also very commonly called crescenteric glomerulonephritis because it presents with this crescent-like shape. I know it's not very clear, but this is what I'm talking about. So this crescent thingy. And here's that same thing, but just highlighted in blue. It's not actually blue, it's just highlighted to kind of visualize that crescenteric shape. And that's all we had for GNs. Thank you guys for coming. As always, any questions, shoot me a message. And please look after yourself and please look after your loved ones.